Thank you for staying on for this lunch symposium today by Menarini timeline. So our primary focus is looking at our decision making in the hormone receptor positive, HER2 negative metastatic breast cancer after they have received initial endocrine therapy, first-line endocrine therapy, and CDK4/6 inhibitors with mutations and new therapies, and how do we evaluate the relevant mutations, and how does that drive our decisions in terms of selecting our treatments and sequencing. So basically, how do we select the right treatment for the right patient at the right time? So for this one symposium, I'm delighted to be sharing the session now with two esteemed faculty members, Dr. Kopibo, and you have Dr. Matteo Lambertini later to share key insights from their presentations today. So, let me start. So, disclaimers and some disclosures. So these are the agendas you can see. So we will start with Dr. Hope later, treating endocrine therapy eligible patients after first-line progression. And then to be followed by Dr. Lambertini with biomarker-driven treatment decisions, evolution of ESR1 testing, and we'll have some time maybe for discussion and question and answer session. So just some housekeeping messaging. Okay. So just a bit of an introduction. So majority of our patients that we are treating today, the vast majority are, treated with our first-line CDK4/6 inhibitor and endocrine therapy for at least 12 months. So these are the patients that we consider a candidate for further endocrine treatment because they are considered endocrine sensitive. So we have a wealth of real-world data showing that, and we have those patients in our clinic. So in terms of subsequent endocrine therapy for these patients, the eligibility criteria has been either, you look at what is the duration that you treat the patient for with the initial endocrine therapy. So you also look at, how many lines of therapy that you have given the patient. And plus we also look at genomic alteration within the tumor, either it is including PIK3CA, AKT, mTOR pathway, or BRCA, maybe RB1 loss, TP53 alterations. And we also have acquired mutations. These are mutations within the tumor that has evolved or developed after you have treated the patient with at least, they are saying up to 50% of patients who have been on aromatase inhibitor. So these are among the criteria that you choose in order for you to see your eligibility for further endocrine therapy for your patients. So in Malaysia, we don't have really updated guidelines, so we rely on ESMO guideline, NCCN guideline, and the PAGA guideline. So as you can see here, guidelines recommend that we exhaust our endocrine therapy-based regimens. We do sequential if we can, the second line, the third line setting, and that would be what is the focus for this lunch symposium today, which will be presented by our key speakers. So without further ado, I welcome Dr. Hope Nicole to the podium to give the first lecture. Hope.
Thanks very much. This is really a whirlwind, I think, of different studies that we'll talk about here for endocrine therapy eligible patients after first-line progression. I can't see this. How did you see that? It's very dark. What is that? That's the thing. The little iPad is something of light. I don't know why.
Big light.
Let's see his. If you can fix it, it'd be great, because otherwise you can't use the microphone and still see the slides. So the screen is dark. Not that it matters, but anyway. May not be fixable. Oh, there you go. Great. Now it's fixed. Okay, so first, ESMO guidelines. So what do we do about assessing what we do after first-line therapy? So the whole thing just shut down. Maybe it doesn't have, I don't know, it's plugged in. So it just, there's something wrong with it. Okay. Looking back and forth. So You know, if I should have a handheld microphone, because there's no screen here. Okay, so as we guidelines do help us decide on sequencing therapy, and patients who have visceral crisis or progressed within the best response to CDK4/6 inhibition is progression. Those are patients where we might be going to chemotherapy. But I think in general, we really want to try for the second line endocrine therapy and the third line in patients who have sensitive disease. And then we're using our biomarkers to try and understand this, both ESR1 mutations and PIK3CA mutations, as well as now AKT and then PTEN loss. And for patients who have germline mutations and BRCA or PALB2, PARP inhibitor is an appropriate approach in the second line setting. You can see that really what the guidelines are using is single agent endocrine therapy, elacestrant, imlunestrant, patients with ESR1 positivity. But for patients who have PIK3CA mutations, or even patients who don't have either PIK3CA or ESR1 mutations, we can use combinations, including with switching a CDK4/6 inhibitor. So there's a lot of different options. And I think that's really where a challenge is that, we have this good option here, and now we have these options in patients who don't have a mutation. But then we also would like to avoid the PI3 kinase inhibitors a little bit longer because of toxicity in some of our patients, particularly those who have diabetes or other reasons why they might have a harder time managing those drugs. But I think now we have a lot of data with combination therapy as well that are challenging what we're thinking about how we sequence therapies in the second line setting. So, of course, we're going to talk about these different areas. We'll talk about some of the historic data. Thank you. Hopefully it will work now. The historic data and the no targetable alteration. What you'll do, we'll talk about each box as we go through. So what about the group where there's no targetable alterations? And this represents probably somewhere in 45% of the patients that we treat. We're going to see an ESR1 mutation about 40%, PIK3CA mutations about 40%, and there's overlap in about half of those patients. And a lot of it depends, again, on the exposure to prior endocrine therapy in developing these subclonal ESR1 mutations. So CDK4/6 inhibitor rechallenge, I think we've now accepted, is an acceptable approach for some patients. But we don't really understand which patients do better if they have a CDK4/6 inhibitor versus single-agent endocrine therapy. We had a phase 2 trial, Maintain, that suggested benefit in specific subset of patients giving ribociclib, primarily after palbociclib. And then we had the phase 3 post-Monarch trial that again showed a benefit, but it was quite small. Although statistically significant, you can see the median was 5.3 to 6 months, and the hazard ratio 0.73, which was quite good. So it turned out that 40% of patients had an ESR1 mutation, and if you looked at it, the patients with visceral metastases didn't seem to do as well, although that wasn't true for the liver metastases, and there was some discordance between investigator assessment and blinded independent central review. So it left us with a little bit of confusion about whether or not this worked at all. And I think it's the data subsequently with oral SERD combinations that's given us more confidence in giving CDK4/6 inhibitors after CDK4/6 inhibitors. I will say that the data that we have almost entirely, with some differences in the most recent studies, has been giving abemaciclib, the smaller phase 2 ribociclib, after palbociclib. So now that we're giving ribociclib in the first line, we really know how these treatments will work in the second line setting, and we need a little bit more information. There are 2 other phase 2 trials. Palbo after palbo did not improve outcome, and palbo again after palbo in the Palmyra trial in older patients, again, there wasn't a significant difference in progression-free survival. Here's post-Monarch looking at CDK4/6 inhibitor rechallenge, and the progression-free survival benefit in giving abemaciclib after palbo, in the subset analyses was after palbo, but palbo represented 60% of the patients treated in this trial. The hazard ratio, though, 0.62. For ribo, no difference. And then there were, a tiny number of patients who got abema after abema, so you can't really tell in that group. In patients with visceral metastases, there wasn't a benefit, but there was in patients with liver metastases, which doesn't totally make sense, of course. And then there was this difference between the blinded independent central review and the investigator assessment in this trial, and it was blinded, so investigator assessment was the primary endpoint, and the blinded independent central review is a sensitivity analysis. So it made for a very complicated assessment. If you looked at ESR1 mutation detected or not detected, for whatever reason, the subsets made it very hard to see an independent benefit, but the trial wasn't powered to really look at that. What you can see also, which I think we've seen in a lot of these trials, is that here you can see 20% of the patients progressed at their first scan. So it's really incumbent upon us to try and understand which patients benefit from this continued endocrine approach with a targeted agent that's in the same class, so a CDK4/6 inhibitor. This may all become a moot point in the future when we have newer CDK inhibitors. There are CDK4 inhibitors in first-line phase 3 trial, atirmociclib. There are CDK2 inhibitors, 2,4 inhibitors, and 2,4/6 inhibitors, all of which are now in earlier phase trials. So we're going to see a lot more data about this in the future. What about everolimus? Of course, we had the Bolero trial, and then we had some triplet studies as well, but none of these, of course, have gone into practice. But everolimus and exemestane initially showed an improvement in progression-free survival that was quite impressive at 7.8 versus 3.2 months, but no one really had a prior CDK4/6 inhibitor. We just saw at San Antonio this year the EPIC-B5 trial, which took forever to do. And that trial showed a significant improvement when you added everolimus in patients who previously had a CDK4/6 inhibitor. So very important data. There's also real-world data combining everolimus with fulvestrant and tamoxifen, all of which showed a benefit and I think has become acceptable in clinical practice. You can see that in the ESR1 mutant population, there also was a doubling in progression-free survival, although this was a subset that wasn't powered for analysis. We struggled somewhat with the toxicity in this group of patients and identifying the patients who benefit the most from everolimus. We don't have a biomarker, so this is a group of patients who, respond reasonably well regardless of whether or not they have alterations in the PIK3CA pathway. We had thought that mTOR would be the key. We would look at downstream from mTOR, and that would tell us who benefited from everolimus. And those were actually, I was part of the steering committee for Bolero in our neoadjuvant initial trial with Jose Baselga, and we never found a biomarker, even going retrospectively and looking with fancier ctDNA techniques. So what about if patients have a PIK3CA mutation or now, of course, AKT mutation or loss of PTEN? And this is actually important. PIK3CA is a clonal mutation, so you have it early on and it continues throughout. But AKT and PTEN, it's a little bit less clear, and PTEN can be missed on ctDNA, especially if you have large deletions. So you want to check once in tissue. That's what we've been talking about at this meeting. So what would you do with these patients? Now, we have, of course, the data from SOLO-1, and then by LEAVE, where we did a single-arm trials where we looked at what would happen with patients who had prior CDK4/6 inhibitors in 3 different cohorts. Cohort A is probably the most reasonable one, where patients had an AI, CDK4/6 inhibitor, and then went on to receive fulvestrant and alpelisib. And we showed a PFS benefit in both, and the PFS differences were relatively similar, but shorter in patients who had ESR1 mutations. As you can see, ESR1 wild type, a longer progression-free survival in by LEAVE. And then I don't have the slides here for EPIC-B5, but this, of course, has also shown a significant improvement. But they didn't look at the subset of patients with ESR1 mutations in order to understand this. And the benefit was only seen in patients who had PIK3CA mutations. And then we had capivasertib, a very potent inhibitor of AKT, all the AKT1 isoforms. And this was combined with fulvestrant in patients who had AKT pathway alterations and showed an improvement in progression-free survival, as you can see here. So we saw a benefit regardless of whether patients had prior CDK4/6 inhibitors or not, and whether or not they had visceral disease. And you can see these hazard ratios do not cross 1, so that was encouraging. And then the safety issues are all something that we manage all the time. Well, we understand that there's stomatitis with the mTOR inhibitors. The steroid mouthwash really has eliminated grade 3 stomatitis, which is helpful, but people do have to use it. It's something that can be challenging in practice, and you have to have it accessible. For alpelisib, I think we struggle with rash and hyperglycemia, even in patients who have a normal glucose when they start. And capivasertib, which is a 4-on, 3-day off regimen every week, you can get a rash, but generally we've been able to control that rash well. In clinical practice, we've heard some stories of rash that was very difficult to control. So we generally, like alpelisib, will encourage patients to use a non-sedating antihistamine when they start. Because I don't know if you have poison oak or poison ivy here, but once your T cells have seen that antigen for the rest of that year, you get a really bad case once you're exposed again to the oil on the leaves. But then the next year you start all over again. So you get a little bit, and then once you're exposed, you get it more. And this is what it looks like with alpelisib. So once you get the rash, then the rash is really bad, and you can't pull it back by using those non-sedating antihistamines. So we do recommend it as a preventive strategy. For capivasertib, it's the rashes are milder, but I think it's very easy to give preventive strategy. And then the other toxicity of capivasertib is primarily diarrhea. You see diarrhea with alpelisib, but it's a late phenomenon as well as interstitial lung disease. Capivasertib, we really see the diarrhea earlier, and we can manage that with drug holds and dose reductions fairly well. So, you just have to think about the toxicities going forward, and you can see where the 9% grade 3, 12% grade 3 for diarrhea and rash, respectively. We'd like to have agents that target this pathway, which is the most commonly clonal mutated pathway that we see in breast cancer. And about 50% of breast cancers will even have PIK3CA, AKT, or PTEN. But we want drugs that are more potent inhibitors and have less toxicity. So there are now 2 drugs that are in clinical trials. The Relay drug, which name I just cannot get out there because it's a brand new name, it's a month and a half old, and then tersolisib, which is the scorpion drug that Lilly is studying in the PICCOLO-2 trial. So there are 2 agents out there that look to have much less hyperglycemia and toxicity and be very potent inhibitors. The results are very encouraging in the heavily pretreated metastatic setting, so we'll see. What about patients who have ESR1 mutations? So EMBER-3, of course, looked at imlunestrant versus standard of care, or imlunestrant and abemaciclib. But if we just look at that arm A and B, which was the primary approach from this trial, the combination arm being added a little bit later, you had 330 patients essentially in both arms, no prior fulvestrant, no prior chemotherapy. And you can see you had 660 patients altogether in this. The primary objective was investigator-assessed progression-free survival in the ESR1 mutant patients and also all patients. So here's the patient population. You can see it's actually interesting, if you look at the PIK3CA pathway mutations, about 50% of the patients had PIK3CA mutations, but they didn't allow patients on, reasonably so, that had primary endocrine resistance, and they didn't require CDK4/6 inhibitors, so about 70% of patients had received a prior CDK4/6 inhibitor. Here you can see that the benefit from imlunestrant was confined to the patients who had ESR1 mutations, and we've seen this in all of the oral SERD trials so far, where you give an oral SERD by itself. And some of the patients were treated in the first line because they relapsed within an early time from their adjuvant therapy, but they didn't have primary endocrine resistance, so they weren't relapsing in the first 2 years. And you can see the hazard ratio is 0.62, and you go from 3.8 to 5.5 months. So it's still less than 2-month median difference. But again, look at this big fall off that we see here. I mean, this is kind of, we don't really know who is going to benefit from this approach or not. You can see about 30% of the patients progressed on their first scan, which is pretty amazing. I mean, once you get the patient population who are going to benefit, they do better. But it's the problem, the medians are really short because you have that big drop-off in the beginning. So the drug is relatively safe. You get some low-grade diarrhea, but imlunestrant overall is pretty well tolerated, as is elacestrant that we'll talk about in just a moment. You can see some low-grade liver enzyme elevations as well. EMERALD was the first trial that looked at an oral SERD versus standard of care endocrine therapy. So, when EMERALD was designed, there was no third arm. And also, we allowed patients on who had received a fair bit of prior treatment. So, CDK4/6 inhibitors were required in this patient population. And then patients could have had prior fulvestrant, and they could have had 1 line of prior chemotherapy. So it's important to keep in mind this is a much more heavily pretreated population of patients. So the baseline characteristics are shown here, and you can see that about somewhere between 20 to 30% of patients had received prior fulvestrant, which is important. Most had received a prior aromatase inhibitor, and then about a fifth of the patients, to slightly more, had received 1 line of prior chemotherapy before they went on the study, and about 70% visceral metastases. Again, CDK4/6 inhibitor therapy was required, and the benefit was seen in the ESR1 mutation population. This patient population, more heavily pretreated, 40% of patients progressed at their first scan, so a big drop-off. But we're seeing about this same median PFS difference, 1.9 to 2.8 months in intent to treat. But in the ESR1 mutant population, it's pretty similar to what we saw with imlunestrant, with a less heavily pretreated population who didn't receive prior fulvestrant, 1.9 to 3.8 months, almost the same delta, and the hazard ratio 0.55. So, although people were disappointed that this wasn't bigger, it really required an understanding of Kaplan-Meier, which is that when you have that big fall off, the medians are much more difficult to interpret, and you have to look at, these specific landmark analyses to see if there's a benefit, and those make a big difference. But we were also interested in trying to understand whether or not, there were differences in terms of endocrine sensitivity. So these are the patients who hadn't received prior chemotherapy, and there you do see a benefit, 1.9 to 5.3 months. Hazard ratio is still about the same at 0.54, so very encouraging. And then we tried to think of surrogate markers for endocrine sensitivity. So receiving a CDK4/6 inhibitor for at least a year was what really came up. And in that group of patients, the median PFS was 8.6 months, so really impressive, versus not even 2 months receiving standard of care endocrine therapy. And you couldn't get fulvestrant if you had already had progression on prior fulvestrant, so those patients got exemestane. And then the ESR1 mutant population, you can see broken down to PIK3CA, all these different sites, greater than or equal to 3 metastatic sites. The numbers get very small here, but it does suggest a benefit across all of these different subsets. And then we recently published 2 papers looking at real-world data. One was looking at the Guardant Health database, and the second was looking at an insurance database in the United States, Komodo, with Foundation Medicine testing. And these were published back-to-back, actually, which was very nice in clinical cancer research. And we looked at patients who had ESR1 mutations who received elacestrant. And this is the Guardant Health looking at time to next treatment, which is a real-world endpoint, and basically showed the median time to next treatment very similar to what we saw actually in the endocrine-sensitive population in the EMERALD trial, so 8.8 months. And that dropped off a little bit when you went to the second and third line. It received 2 or 3 lines of prior endocrine therapy. So it was, as you would expect, better if you had less endocrine-resistant disease. And then in the insurance database, we had a slightly smaller number of patients. And again, we saw a very similar time to next treatment, 10.8 months in this patient population. So if you compare all 3 of them, here are the real-world 2 data sets, and then the phase 3 EMERALD trial, you're seeing very similar median progression-free survivals, which is quite encouraging. And if you looked at patients who had coexisting ESR1 and PI3 kinase pathway mutations, you also saw that this PFS was maintained in that population with single-agent endocrine therapy that's very well tolerated. So I think that's important. If we can identify the patient population most likely to benefit, these patients are receiving treatment where they have no hair loss, no IV need, they can travel. These patients are going to eventually die of their metastatic disease. So we really do need to understand which patient population this is. And then after CDK4/6 inhibitors, elacestrant is similar benefit in terms of combination therapies. Now, the problem with this, of course, is that you're comparing apples to wave fruit. I mean, it's really, you can't do cross-trial comparisons well like this. And if you look at the numbers, 27 patients in EMERALD, 27 patients in BYLieve, it's actually very hard. I think for us, really, it's looking at the toxicity profile, trying to understand what's going to be best for our patients and best to manage, and whether or not we could use our PI3 kinase inhibitors that we have now, or AKT inhibitors, sequentially. And in the most endocrine-sensitive settings, use in oral SERD in place of, sort of in the second-line setting, and then go on to the combination therapies that are a little harder to manage. And elacestrant's very well-tolerated. Nausea is a toxicity seen in about a third of patients, but can be very easily managed and is rarely high-grade. Really, in my experience, I've ever seen one patient who really had a lot of nausea from elacestrant. Taking it with food really manages the nausea well. And we don't see any flashing lights, which we see in some of the oral SERDs. We don't see bradycardia. So this is, helpful to know that none of those things really need to be monitored for. So what about looking at the combination studies with oral SERDs? So, of course, Arm C of EMBRA looked at imlunestrant and abemaciclib, 70% of patients exposed to prior CDK4/6 inhibitors. It was compared to Arm A. But what's important to keep in mind here is this is where they started the Arm A. So it's not compared to the whole Arm A, but to 213 patients in Arm A. And again, the investigator assessed PFS. In the intent to treat population, where 2/3 had a prior CDK4/6 inhibitor, progression-free survival was much longer, 10.9 versus 5.5 months, hazard ratio 0.59. Very encouraging. And the fall off here, this is a less resistant population overall in terms of, it's maybe hard to know exactly, but in the 10 or 15% who progressed on the first scan. So it's not the same population, which is really important to keep in mind when you are looking at cross-trial comparisons. In terms of the benefit, it was interesting that there was actually less diarrhea than we thought there would be normally. I don't know if it was patient selection or management, but only 20% grade 3 or greater diarrhea with abemaciclib at 150 milligrams BID, and a drug that causes a little bit of diarrhea, imlunestrant. But overall, it was quite well tolerated, and the neutropenia that was seen was really exactly what you would see in patients receiving abemaciclib at 20%. But, I don't know that there's any other study that's shown an 8% rate of grade 3 diarrhea with abemaciclib. So it's kind of an interesting phenomenon in this group of patients. We also have done a phase 3 trial of giredestrant and everolimus with the initial data presented at ESMO and then updated data at San Antonio, where we compared giredestrant to standard of care endocrine therapy with both arms receiving everolimus. This group of patients had to have endocrine-sensitive disease, so at least 6 months of prior therapy with a CDK4/6 inhibitor. All had to receive a CDK4/6 inhibitor, and none were allowed prior chemotherapy. And our endpoint, of course, was progression-free survival, both in all patients and those with an ESR1 mutation. So the baseline characteristics are seen here. About 70% of patients had received their CDK4/6 inhibitor for 12 months or longer. And the trial was designed to have 55% of patients with an ESR1 mutation. You can also see that about a third of the patients had a PIK3CA mutation, but the alterations overall were a little over 40%, which is a lot of patients with that alteration. Also, you were allowed to receive prior fulvestrant in this trial, and about between 29 and 22% of patients received prior fulvestrant, and actually less than the standard of care arm, so you would have expected it to impact the giredestrant arm more. Well, what we saw was in these co-primary endpoints a significant improvement in progression-free survival using giredestrant versus standard of care endocrine therapy, which could include exemestane or fulvestrant. And this was true in the intent to treat as well as the ESR1 mutant population. You can see these really big differences at 12 months, 15 versus 40.5% progression-free. In terms of the toxicity, there didn't seem to be any added toxicity from giredestrant. It was mainly stomatitis. When I looked at that, I was like, boy, they didn't use enough steroid mouthwash there. But there was very low, high-grade stomatitis, so that was encouraging as well. And then grade 1 to 2 bradycardia was seen at 3.8%, but no high-grade bradycardia and none of the flashing lights called photopsia. So that was encouraging. And a fairly low rate of discontinuation. Mostly the discontinuation was slightly higher with everolimus, but patients stayed on therapy for longer, so that may have contributed to that. We also have looked at elacestrant in combination with everolimus as well as with abemaciclib. Interestingly, on our phase 1b portion of ELEVATE, we found that you could take 7.5 milligrams of everolimus with elacestrant and have the same drug exposure as 10 milligrams, but less toxicity. So, we never evaluated that really well in when we were studying everolimus initially. So we had 50 patients who received elacestrant and everolimus and 60 patients who received elacestrant and abemaciclib, and presented this data at San Antonio. Half of the patients in the abemaciclib cohort had received prior CDK4/6 inhibitors, and half had not. And it was full dose for the abemaciclib. So we were very impressed with the phase 2 results of elacestrant and everolimus. Even though the dose is at 7.5 milligrams, the median PFS was 8.3 months, so very similar to what we've seen in some of these other trials. Very encouraging, even though 50% of the patients had received prior fulvestrant, which is, I think, really interesting that you could overcome that resistance. And we looked at the patients to see whether or not there was a difference, and you had the same benefit whether or not you'd received prior fulvestrant, visceral disease, and patients who had ESR1 mutations or not, although the numbers are small, and PIK3CA wild type or mutant. Follow-up time here is a median of just 4 months, but we came to our medians in the population. And then in terms of toxicity, there was no unusual toxicity, but I think it's nice to see that stomatitis be really low in the patients who are receiving 7.5 milligrams. And I know there's no bradycardia photopsia with elacestrant, low rate of drug withdrawal. So what about elacestrant with abemaciclib? So here again, half of the patients had a prior CDK4/6 inhibitor and half not. We're seeing a really marked progression-free survival of 14.3 months in this population of patients. There were all about 30% of patients who had prior fulvestrant in this group, so a little bit lower. And we don't have the median yet in the arm to understand what the impact of prior CDK4/6 inhibitor therapy is yet, or ESR1 mutations. But you can see that if you look across these groups in the combined population, it's all over 14 months, so very encouraging. And here you can see the safety profile, which is exactly what you would expect from abemaciclib plus standard endocrine therapy. No increased toxicity and no higher grade toxicity. Low rate of drug withdrawal at 0% and drug reduction in only 5%, so very encouraging. There's an ongoing oral SERD combination study called ADELA, which is looking at elacestrant and everolimus versus elacestrant and placebo. So again, this is one of those combination versus single agent trials, but it is in 240 patients. It's ongoing and enrolling patients now. Primary endpoint is looking at progression-free survival based on blinded independent central review, although this is placebo-controlled. So second-line treatment choices, as I've shown you, are defined by, of course, the first is how do we understand if a patient has endocrine-sensitive disease? And I think it's a big challenge for us, but, patients whose best response to a combination of CDK4/6 inhibitor and endocrine therapy is progressive disease is not one of those patients. We found, based on looking at the EMERALD trial, that being on your CDK4/6 inhibitor and endocrine therapy for at least 6 months, at least 12 months, does predict better endocrine sensitivity. And we've actually seen a little bit of data between 6 and 12 months, but I think at least 12 months is a pretty good determinant. If a patient has a mutation like PIK3CA mutation, ESR1 mutation, they are having progressive disease at 8 to 10 months, still trying another endocrine therapy that targets this resistance mechanism, I think is quite reasonable. And we've seen benefit in those settings. But we want to try and eke out our endocrine therapy for as long as possible for these patients. And then we have very good options for deciding about whether we start with an ADC or oral chemotherapy in the first-line chemotherapy setting. The EMERALD population, I think study population, reflects real-world practice, 100% prior CDK4/6 inhibitors, a high rate of visceral metastases, prior fulvestrant, prior chemotherapy. These are all patients who can potentially benefit if we can just assess the endocrine sensitivity. And the real-world evidence that I showed you, which was recently published, I think confirms this data with a long time to next treatment of 8 to 11 months in line with the EMERALD trial. So Ellis, I think, a big question came up with all of these combination studies. Is there still a patient population where we would give single agent oral SERD? And I think our very endocrine sensitive patients, so patients who maybe have de novo metastatic disease or have a very, very late relapse, they stay on the first-line therapy for many years. I had a patient who was on, and it's really fascinating, she was on her first-line therapy with anastrozole for 8 years, lobular cancer, progressed with bowel obstruction, was on a bunch of therapies. She was on a Palbo dose-finding trial we had on, and, she responded to 100 and then 125 milligrams capecitabine, and eventually I put her on trastuzumab deruxtecan. And she's about 80, and she runs this big, huge business in teaching science education through interactive media. And it's actually fascinating. Her books are in the children's bookstores, and she has a big website, a big international library. So she came to me, she got 3 doses, everything got better, the obstructive system symptoms went away. And she said, I'm not doing any more therapy. I'm going to sell my company. I can't get out of bed. This is terrible. And I said, we'll dose reduce. She said, no, I'm not taking this drug anymore. But I see that last NGS said that I had an ESR1 mutation. I want to take that drug, elacestrant. And so I said, well, but I don't know that it's going to work after 2 lines of chemo and 3 different lines of endocrine therapy with targeted agents. I said, I'm happy to do it. You don't have symptoms now. It's a good idea. So we gave her elacestrant, and she actually stayed on for almost 2 years. So, and just recently restarted TDXD after 1 year and just under 2 years. So amazing thing. In that time, she built her company up more. She didn't sell her company. It's really been amazing. So I think that we do need to understand which patients will benefit the most from this treatment. And with that, I'll turn over the podium to Matteo Lambertini. Thanks.
Good afternoon, everyone. Thanks a lot for the kind invitation and the opportunity to contribute to this symposium, and thanks to Menarini for the invitation. So I'm going to talk about the testing part, which is very critical. Professor Ugo has discussed a lot about patient selection, the importance of these endocrine sensitivities, which is relevant to select for a second-line endocrine-based therapy. And in this more endocrine-sensitive population, we do have now a PFS beyond 8 months, as we've seen. But the testing part is also a critical component of this patient selection for second-line therapy. And I will say that this probably has been, I will say, an historical moment in the breast cancer field, because it's the first time that we have finally implemented the liquid biopsy into our routine clinical practice. And when this drug came to our clinical practice in my country a couple of years ago, this part was, I would say, probably the most complicated part, because we are definitely fully convinced on the efficacy. We are definitely very happy to use new agents, new targeted therapies. But the testing part, at the beginning, it was quite difficult to be sort of accepted or implemented. So it's where I think we need a little bit of attention on how to properly implement the testing part. So I'm sorry that I'm going back to the to this slide that also Dr. Mastura presented at the beginning of the presentation. But I think this is important to highlight the concept of actionable alteration. So alteration, genomic alteration, including, for example, gene mutation, that can be targeted with an effective therapy. And we are talking about oral SERD, which are, for example, effective in ESR1 mutated cases. When we talk about actionable alteration, we do have two different types of alteration. One group of alteration that we call intrinsic mutation, intrinsic alteration, or a truncal alteration. This means alteration that are there since the beginning of the cancer development. For example, the alteration of the PI3K pathway, in most of the cases, they are there since the beginning of cancer development. So meaning that if you test a primary tumor or a metastatic lesion, the chances to find an alteration in the PI3K pathway are very similar. There are also some acquired alteration in this pathway, but the vast majority are truncal alteration, intrinsic alteration, so they are there also in the primary tumor. If we talk about oral SERD, and particularly ESR1 mutation, we are talking about subclonal alteration, acquired alteration, meaning alteration that arise during treatment after progressing to special therapies. So if you test for this alteration, the primary tumor, it's very unlikely to find this acquired subclonal alteration. So these are mechanisms of resistance to other treatment, and we are talking about ESR1 mutation as a mechanism of resistance to endocrine therapy. So ESR1 mutation is our mechanism has acquired endocrine resistance. So it's acquired under the selective pressure of endocrine therapy, particularly aromatase inhibitor-based therapy, but is more in general endocrine-based treatment. They are subclonal and heterogeneous, so they may not be found in all cancer cells, and they may arise later on during treatment. They are commonly affecting the ligand-binding domain of the estrogen receptor alpha, resulting in a ligand-independent ER activation and constitutive signaling. And it's one of the main mechanisms of acquired resistance to endocrine therapy that we know and that we can target these days. This is a very important graphical representation of the concept of acquired versus subclonal alteration. So if you test in the adjuvant setting, if you test the primary tumor, very unlikely to find the ESR1 mutation. And if you remember on the first day when we discussed the lidERA trial, the giredestrant data in the adjuvant setting, this was clearly discussed by Lisa Cari at the San Antonio conference. It's very unlikely that the presence of ESR1 mutation justify the benefit of the treatment, because in the adjuvant setting, it's very unlikely to find such alteration. Even in patients progress, like developing disease progression, so at the time of before starting first-line therapy, the rate of ESR1 alteration is relatively low. I would say it's less than 10%. While for patients that have received a first-line treatment and the longer the exposure to first-line endocrine-based therapy, which is CDK4/6 inhibitor plus endocrine therapy, in the vast majority of patients, the higher the likelihood to find this alteration. So we see that in the second-line setting, we expect around 40% of patients that can become even 50% in the third-line setting. So we do have also some patients that may receive a second-line endocrine therapy without a ESR1 alteration, and then at the time of progression to second line and are tested again, we may find and we can offer this option to an extra 10% of patients. So this is a real world study from the US, including almost 300 centers with the foundation medicine testing, and looking at the rate of positivity, so the chances to find a ESR1 mutation by looking at the primary tumor as compared to the liquid biopsy, to the ctDNA. And as you see, the chances to find the ESR1 mutation, it's much higher in the liquid biopsy as compared to the tissue. And this is why we should consider the liquid biopsy as the best tool to test for this type of alterations. So if we look at what's the pros and cons to use the tissue versus the liquid biopsy, particularly for ESR1 mutation, tissue biopsy, low sensitivity for ESR1 mutation. You have seen lower chances to find it. If you test the tumor, it's, as we know, is an invasive procedure with long turnaround time. This is, again, wide alteration, subclonal alteration, and in this case, because of the heterogeneity of advanced disease and also within the tumor, all mutation may not be detected. So maybe a patient with different sites of metastatic disease, we biopsy only one of these sites, and then this is probably the critical point, the most important point, also highlighted by the guidelines that we're going to see in the next slide, that we should not use at all the primary archival tissue for looking at the ESR1 mutation, because we are not going to find it. So it's different as compared to the alteration in the PI3K pathway. So liquid biopsy, why is the preferred method for ESR1 alteration? Because it has a high sensitivity, it is a minimally invasive procedure. It can be also repeated over time without bothering the patient too much. It's a fast sample acquisition, and then it's a better measure of tumor heterogeneity, which makes a difference when we talk about subclonal alteration. In terms of which type of testing to be used, normally in our practice, we mostly use NGS testing because we can test for more alteration at the same time, but this alteration can be picked very well also with simple digital PCR assays. In terms of guidelines, they are all very consistent. This is a snapshot of the ESMO, NCCN, and ASCO guidelines with three main important messages. The first one is that the liquid biopsy is the preferred method for testing for ESR1 mutation. Second important message is that you may need to test more than just one time, because as I mentioned, the more exposure to endocrine therapy, maybe more lines of endocrine therapy, the higher the chances to find it. So a patient progressing on first line, if we cannot find the ESR1 alteration, at the time of progression to second line endocrine therapy, we feel that we can still offer an endocrine-based treatment option. We should retest the patient. And then again, I want to stress one more time the point that the primary tumor should not be tested for ESR1 alteration, because it's very unlikely to find this alteration. So the main key takeaways for this biomarker-driven approach is that the second-line treatment choices are defined by the eligibility to receive endocrine therapy and are driven by biomarker status. So as you have heard from Professor Ruger's talk, nowadays we are, I would say, a bit better to select who are those patients that can benefit from a second-line endocrine therapy. This is a more clinical choice, clinical selection of the patient based on the PFS to first line. But then the biomarker part is also highly relevant to select our second-line treatment, which can be an oral SER for ESR1 alteration, but also other targeted options for other genomic alterations. Around half of the patients may have the ESR1 mutation when exposed to prior endocrine therapy in the metastatic setting. And if you remember, almost none of the patients in the early setting, and around 10%, probably less than 10%, at the time of diagnosis of metastatic disease. ESR1 mutation can be tested at each progression because they are, again, acquired alterations, so they may appear later on during treatment. And because they are subclonal and heterogeneous, they are not always detected with the tissue biopsy, so the preferred method is the liquid biopsy, and definitely never use the primary tumor, the archival primary tumor, for testing for any ESR1 alteration. And with that, thank you very much for your attention.
Okay, so we now move to the question and answer session. Is there any question from the audience? Yes, Ryan?
Yes, thank you for the great talks. Just a question to Prof. Rigo. You mentioned early in your lecture there was the algorithm, and you also mentioned that PIK3CA is a clonal mutation. So I'm wondering if I have a patient whose best response to first-line CDK4/6 inhibitors at 4 months was progression, but the initial tumor biopsy actually shows a PIK3CA mutation. Would you be tempted to try still to give, let's say, a capivasertib and fulvestrant?
It's a great question. I think we face this all the time. I think sometimes it can be very hard to determine that somebody's really progressing. I mean, if they have multiple liver mets, that's a little different than having, some increase in SUV in the bone mets or new lesions appear, because as we all know, that can sometimes represent a treatment response as well. So I think that decision is really going to be based on what the progression is. So if it's primarily bone, somebody's not very symptomatic, you can manage the symptoms, I would definitely try. For a patient, because you really don't want to get, not have that option for a patient. And sometimes we'll see that, cancer really wasn't as, progressing. I think that's the bottom line, is that it really was a marker of maybe a response to therapy. But if somebody's developed, 25 new liver lesions, then I probably wouldn't. So I think it really depends on the phenotype. Your thought?
I fully agree on the clinical selection part. For the biomarker part, we have data, and we have data also in the Emerald trial, that in the presence of a co-alteration, the critical alteration for the efficacy of the oral SERT is the ESR1 mutation. So the efficacy that you see in the ESR1 mutated population is observed regardless of the presence of other alterations. So even with a co-mutation, you have the same benefit if you have ESR1 mutation. So yeah, I will just add that on the top of the clinical decision, which is very...
And I think that's really important. But in these patients who are progressing at 4 months, I don't think we rescue them with oral SERDs well, because I think you really need some other target that targets a resistance pathway. So that's where the PI3 kinase, inhibitor would take a frontline role, as opposed to, for example, trying an oral SERD in combination with a next CDK4/6 inhibitor, everolimus. I would be more concerned if a patient's cancer was truly progressing at 4 months.
Thank you.
Maybe on the clinical selection part. So if you're discussing a patient that has progressed like 4 months after starting a first line CDK4/6 inhibitor plus endocrine therapy, this is a patient that may be potentially ineligible to a second line endocrine based treatment. So the clinical selection is still critical.
Maybe if we knew it earlier, we may want to get INAVO if we knew it earlier.
If somebody fits the criteria for INAVO 120, obviously you can try the triplet. And, it's really fascinating to look at the real world data and show that, so few people actually go on to second line endocrine therapy. Some people don't even get second line therapy, which I always find perplexing, because we don't really see those people in practice. But real world data suggests, at least with the caveats of real world data, that there is a subset of patients who don't. So I think if somebody does have rapid recurrence and a PIK3CA mutation, and they qualify for INAVO 120, I think that's a very really good approach. For patients who maybe are going to have more toxicity, for example, unstable hyperglycemia, or for patients who are relapsing later or have de novo disease, we just don't have the data yet to, I think, justify the triplet treatment. I don't know what you think.
The only point of the INAVO 120 trial is that this is a first-line trial in the endocrine-resistant population, so this will not apply, for example, in a patient with de novo stage 4 disease. Even with the PIK3CA alteration, she will not be eligible to the INAVO regimen. So this will become as a second-line treatment choice. But yeah, in the endocrine-resistant space, it's not available yet in my country, but it's something that I'll definitely consider. And this is also important for the testing, because in that case, you can also test the primary tumor. Again, it's a PIK3CA alteration. In the vast majority of there are very few acquired alterations, so you can also test the primary tumor, which is not the case for ESR1 alteration.
Thank you.
That's just it.
Can I ask a question about VAF? Because if ESR is rare in primary tumors and they emerge after selection pressure due to treatment, so we have data to show that regardless, they respond equally, right? So, but there are a lot of discussion and noise about VAF. Can we make me understand more about that?
Yeah, on the response part, the data that we have suggests that this is regardless of the variant of allele frequency, and also we do have data with the co-mutation as well, that even if maybe there is a higher variant of allele frequency for the PIK3CA alteration, still there is a response also with the oral SER. So in the presence of a ESR1 alteration, I will not bother, to be honest, on that. So I will go for an oral SER.
I think what's interesting about the VAF is that we don't have that data, much as we've been trying to look for it. That, if you have 0.1% versus 10% or 40%, I mean, you don't really know what impact that has on your response to the treatment. I mean, we just have no data. Now, there's not a lot of push on our partners, who are doing the studies, running the studies to do that kind of analysis. And I think it can be quite complicated based on what you're looking at. But that's part of, this Taylor switch, what we're looking at in terms of rising ctDNA is to look at the VAF and have a cutoff for where the ctDNA is actually rising. And that's based on data from a number of different settings. But it's been an interesting question. I mean, big thing in designing this trial has been, Francois Clement Bedard has been working on is what should the cutoff be for the VAF? Because, what means that it's going higher if you're looking at all ctDNA, not just ESR1. And then we see this, like somebody has a somatic BRCA mutation and it's like 0.1%. Should you try a PARP inhibitor in that setting? And I have to say, I've had patients who've responded to treatment with very low VAF percentages. So I always think it's worth it.
It's the same situation where people ask, how many ESR mutations are there? Because it doesn't matter, right? They still respond.
Yeah, I mean, I think that there's some data that patients who have multiple mutations don't do quite as well with any treatment that you give. And we first, I think, showed that in Bolero too, actually. You had lots of mutations. People did terribly, and they didn't respond to endocrine therapy. I don't know of any good data with multiple ESR1 mutations. Yeah?
Maybe on this part, I didn't talk about that during the testing part, but also the pre-analytical part is very critical when you do a liquid biopsy. I've heard that for those of you with some experience, probably some of you has mentioned that the rate of ESR1 mutation that you can find in your population is lower as compared to this 40-50% that I've mentioned, which is not my practice, to be honest. Like progression to first-line setting, I would say that around 40% of the patients, so a bit less than half of the patient, will have this alteration. And I think the pre-analytical part is critical. So the way you do also the blood drawn and the timing from the blood drawn to the processing of the...
What about putting the blood, the tubes in the fridge?
I mean, you need to process that within 15 minutes from the blood drawn, which for having higher chances to find it. So this is something that also should be implemented when you start the first thing. Minutes for the first process. Sure.
Pre-analytical. Any question for the audience?
For patients who are hormone receptor positive, we rarely do NGS testing from the start, and only on progression many years later, for example, where they are on adjuvant therapy. So to check on whether there is changes in the ER status, ESR1, PIK3CA, which is the most common. But because you are saying that the tissue is less sensitive for ESR1, are you suggesting that we should be doing both the tissue and liquid?
Yeah, thanks a lot for the question. So this depends what you are looking for. So when a patient has a recurrence, we normally do a tissue biopsy because first we want to confirm it's metastatic disease. We want to reassess ER, PR, HER2. And then, for example, if it's an endocrine-resistant case, so this patient has progressed on adjuvant endocrine therapy, and you have the INAVO 120 approach available, which is BCA inhibition in the first line, then I will NGS testing at that point on the tissue. That could be the primary tumor or the metastasis for looking at PIK3CA alteration. If you are talking about the patient progressing on first-line endocrine therapy plus a CDK4/6 inhibitor, then the liquid biopsy is the preferred approach. In our case, also for the PIK3CA alteration. So we start first with the liquid biopsy with this panel in which we have also PIK3CA alteration. And then if we cannot find anything on the liquid biopsy, we go for the tissue sample for the PIK3CA, AKT, and PTEN alteration. So it depends what you are looking for.
Okay. I want to ask about in the second line setting, if the patient is a candidate for endocrine therapy, not in organ crisis, but a lot of tumor burden. A lot of tumor burden. So the patient has ESR1 and patient has PIK3CA, so coexisting mutation.
Been on their endocrine therapy for more than
CDK4/6.
for more than a year.
Yeah, more than a year.
So the question is, if you have a lot of tumor burden, does it influence your choice of treatment?
Is it mono or
and a lot of I think it depends. Like, is it a lot of bone mets, or do you have liver mets? And yeah, I mean, it's so hard to know. I think if somebody stayed on for a long time, and you're worried about the toxicity of the PIK3CA mutation, you could always try. But otherwise, I would combine with. Now we don't have the data for oral SERDs, but we will in the not too distant future with capivasertib. But otherwise, I think you could use now an oral SERD with everolimus, which I think might be our go-to. I don't know what you think.
I fully agree. I will definitely discuss openly the different options, also the toxicity profile, the way the treatment are being taken, and then also potentially thinking if this is a patient potentially candidate to a third-line endocrine therapy, so a potential sequencing, that will also go into the discussion.
let's come. But people seem to think that if you give 2 drugs, always better than one. That's the idea. Whenever they say they're thinking about tumor load, tumor burden, they think better give 2 because that's just a.
I think we've seen that now from the trials. I mean, there's a select group of patients who could use single-agent endocrine therapy in the second or later line setting. But in general, I think we're going to be using combination therapy.
Good.
Any other question? Could I have another question? If there's no other question. Kaid?
Okay.
The last question is actually for EMBER-3 and Elevate, I think. Either you have ESR1 or no ESR1, patients seem to be benefiting. So,
I will leave Professor Ugo addressing this. No, it's true. Like with these combination trials, we are seeing that apparently the biomarkers seems to be less relevant as compared to what we've seen with single agent, even though most of the benefit is driven by the biomarker selective population. So if you look at the ITT population, that include also half of the patient with the genomic alteration. So most of the benefit is still driven by the biomarker. And then in some of this trial, which is different from the Emerald trial, 30-40% of the patients were not exposed to a CDK4/6 inhibitor first line, which is not the case in Emerald, where 100% of the patients were pre-treated with a CDK4/6 inhibitor. And that's why also the control arm performed better in this trial than in Emerald.
Yeah, and I think, in Elevate, we saw benefits even in patients who were ESR1 wild type, which is certainly encouraging when we use combination therapy. And we still have the data with the abemaciclib to evaluate because we don't have the medians yet for that. But then in the giredestrant, Avera trial, it was actually quite interesting. It was powered to look at intent to treat and ESR1 mutant population. Only 45% were wild type, right? Or non-mutant was the terminology. And there was, if you looked at that subpopulation, the PFS looks like it's not better, but the overall response rate was better. And so, you were powered enough to look at overall response that was really much better in the giredestrant treated group, despite the fact that there wasn't a mutation. But you didn't see that difference translate into PFS, and presumably that's a powering issue. I think we'd all like to give an oral SERD instead of fulvestrant to many patients. And so we're really trying to search that data to understand whether or not that will be feasible in the future, but we need our regulatory advisors to agree.
Did you enjoy my letter? I thank you everyone for staying.